So today I'm going to talk about supraventricular tachycardias, and the focus is going to be on the narrow complex tachycardias. So I'm Dr. Vinod Thomas. That's quite difficult. Most people call me VT, and I promise you I did not choose my specialty because of my initials. So the big five. Atrial tachycardia is very common. Then we go to atrial flutters. Now, atrial tachycardia is generally a focus that fires away. If there are multiple foci, that's multifocal atrial tachycardia, and if it's multiple wavelets, one gets atrial fibrillation. Atrial flutter, on the other hand, is not a focus, it's a macro re-entry circuit. Now, these usually occur in the atrium. The rest of the tachycardias are what we call AV node-dependent tachycardias, and that includes the prototype, AVNRT, atrioventricular nodal reentry tachycardia, and this is something that's just localized to the AV node. Atrioventricular reentry tachycardia, it goes from the atrium to the ventricle and involves the AV node, that's called AVRT. And then there are junctional tachycardias. Now, junctional tachycardias are a lot more common in children, and so I'm going to leave it out of this talk, so hence it's a big four. So what's a supraventricular tachycardia? The supraventricular tachycardia is anything above the ventricle. And that's the atria or the AV node, and perhaps the His-Purkinje system, but we'll focus on the atria and AV node here. So SVTs generally have the same QRS complex to the sinus rhythm QRS, except it's a lot faster. And the reason is because the SVT involves the conduction system, it has a narrow QRS in general. Now, for every rule, there is the exception. And if you've got an SVT with a bundle branch block, that's your wide complex tachycardia. Or if your SVT uses an antegrade accessory pathway, that's a wide complex tachycardia. Like I said, this has been excluded from this talk. It's not a sinus tachycardia that has this feature. It probably is an atrial tachycardia. If you've got an SVT that has a sudden onset and sudden offset, and usually I find it in the runners, they say they're busy running, they're running at a rate of 130, 140 beats per minute, and suddenly their heart rates jump up to 180 beats per minute, and they really panic, they stop, they sit, the heart rate still stays at 180 beats per minute, they cannot bring it down, and then over 30 minutes it suddenly drops down. That suggests AVNRT or AVRT. Okay? If, for example, your patient tells you, I coughed, or I put my head in cold water, I don't know why they do that, or I did a carotid sinus massage and it terminated the tachycardia, then you're most likely dealing with AVNRT and possibly AVRT. The other clue is patients coming in with a rapid heart rate that's regular, you've done an ECG, it's a narrow complex tachycardia, and you can see the neck bobbing away. That's usually Canon A waves, and you see that in AVNRT. You've got an atrial tachycardia in front of you that's going very fast. You don't know what it is. You give carotid sinus massage or adenosine. I'll come back to that just now. And you see the ventricular rate slows down and maybe even irregular. That suggests it's an atrial tachycardia, atrial flutter. Okay, how do you do carotid sinus massage? Lie the patient down, check for bruise, because you don't want your patient to stroke out. So if they've got bruise, don't do it. You feel the Adam's apple, you go lateral, feel the pulse, and you go one finger breadth above to the angle of the jaw, and you rub round and round in a slow circulatory fashion, and it engages the vagal system and the AV node, and if you get the following response, the heart rate slows down, and when you stop, it picks up again. You're dealing with either a sinus tachycardia or an automatic atrial tachycardia focus. If you give carotid sinus massage and P waves suddenly come out, you're either dealing with an atrial tachycardia or an atrial flutter. Now, it's very important to, when you give carotid sinus massage, to please record your rhythm strip, because other people may find it useful for interpretation. If you give carotid sinus massage and the tachycardia terminates, it's a good chance you've got AVNRT. Okay, so now you've got this SVT in front of you, and you can see a P wave very clearly. If the P wave looks very similar to sinus P waves, and a sinus P wave is a P wave that is positive in V1 and positive in the inferior leads 2-3 AVF, negative in AVR and AVL, that is a sinus P wave. It may be sinus tachycardia. Please don't shock this patient. Don't give him adenosine. Just treat the mechanism for the sinus tachycardia, which is usually sepsis, fever, he's on adrenaline, or hypothyroidism, possibly even pulmonary embolus. If you exclude all the above, and this patient has a sinus tachycardia, it's called an inappropriate sinus tachycardia. Now, this we often see in young females, and this is a variation of your POTS syndrome, okay? But this is not uncommon in young females. Sometimes you get a sinus reentry tachycardia, similar mechanism to how a normal reentry tachycardia is set up, and that is what your mechanism of your tachycardia is. If your P wave looks very similar to sinus, and you're convinced this patient has an atrial tachycardia because of the automatic nature of it, it may be what we call a crista terminalis tachycardia. And these usually respond to adenosine, by the way, and carotid sinus massage. So it can be very confusing. The last group is this right superior pulmonary vein tachycardias that come from the right superior pulmonary vein. And these is a tachycardia that looks very similar to sinus tachycardia. And these patients sometimes break out into atrial fibrillation. So what if the P wave looks different to that in sinus tachycardia? Okay, if you've got more P's than the QRS, and it has a seesaw pattern, which I'll show you later, it's atrial flutter. We use IV amiodarone. Now, I don't believe IV amiodarone actually works on atrial flutter. I think you're just lucky that it slowed it down and cardioverted it. I actually think that it may paradoxically worsen your ventricular rates, because as you slow down the flutter circuit, it starts to conduct one-to-one to the ventricles. So you've got to be very careful about that. And like I said, even when you've cardioverted them to normal rhythm, these patients are predisposed to going back to flutter because they've got the right sort of substrate. So they will probably go back into flutter. So if they go into flutter despite cardioverting them, you can send them for a flutter mapping and ablation, and we'll get them into normal rhythm and keep them there without medication. Okay. Atrioventricular nodal reentry tachycardia, that's within the AV node. What are the clues? If you catch it and you see how it starts off, and it starts off with a prolonged PR interval, and during the tachycardia, the P wave has a concentric activation, I've already explained that to you, with a very short RP interval, that is typical AV and RT. If it terminates with vagal maneuvers, carotid sinus massage, and adenosine, you're probably dealing with typical AV and RT if you've got all the above features. However, you can have atypical AV and RT with a long RP interval. Is it regular or irregular? If it's irregular, probably AF. If it's regular, try and see if you can see a P wave. Then you decide if you can see the P wave morphology and the relationship of this P wave to the QRS. Then you try and determine the PR and RP intervals. If you cannot see the P wave, AV and RT. If you can see the P wave, it can be atrial tachycardia, AV and RT, or AVRT. If the patient's unstable with these features, cardiovert him right away. You don't have time. If it's stable, you can give carotid sinus massage, adenosine. Recall the rhythm strip. It's very helpful for me when it comes for an ablation. Your long-term therapy can be conservative, pharmacological, or invasive, depending on how aggressive you or your patient want to be, or how bad, what condition they presented in. AV nodal blocking agents have 60% success rates in most of these cases. However, I think EP studies and ablations for SVTs are very, very good, and we go at 90% success rates. Thank you.